Thanks very much for having me and welcome. I was asked to give a little bit of my perspective today on how I care for patients following completion of treatment for anal cancer in the context of my medical oncology clinic. And Albert gave a very comprehensive review of how we treat patients, and I want to talk a little bit today about life after anal cancer. I'm going to just give a few slides of background for the sake of interest, and as I reflected on the fact that there are so many of you here today, I wanted to point out how rare of a disease this is. Anal cancer, in terms of all of the cancers that we treat here in the Cancer Center and nationwide, is the 26th in terms of incidence. In 2014, it was estimated that there would be approximately 7,200 new cases of anal cancer, and an estimated 950 people will die of this disease. Survival after anal cancer is pretty good. In terms of the diseases that I treat, it's one of the best, with approximately 65% of patients, or 2/3 of patients, making it to 5 years following completion of treatment. This number is, of course, variable based upon disease stage at time of diagnosis. 65% still isn't good enough, and just as a sobering fact, here you can look at the time trend, that in fact, going back to 1975, the 5-year survival was 65% even then, so we haven't made much improvement. So these are the topics that I'm going to touch on today. What happens after completion of treatment? Surveillance is really important as a medical oncologist, and we follow our patients out to 5 years after completion of treatment. Long-term toxicities include bowel dysfunction, changes in bone density, and sexual dysfunction. And then the question that I hear all the time is, what else can I do, doctor? Fear of recurrence is an issue that's particularly important to me, and is something that I think is very pervasive in the growing number of cancer survivors that we see here in the Cancer Center. Dr. Chang touched on this, but this is an overview of the surveillance guidelines from the NCCN, and I put this up here to just show you how vague they are. So for a patient who is in complete remission after completion of treatment, it's recommended that every 3 to 6 months for 5 years they undergo a digital rectal exam, anoscopy, inguinal lymph node palpation, and then that we think about a chest, abdomen, and pelvis CT annually for 3 years. In practice, that is not necessarily what every single one of your medical oncologists and radiation oncologists does. Typically, we look after about 3 to 4 months with a PET CT scan, and we're very, very vigilant about looking for early evidence of persistent disease, because that definitely stratifies how we follow patients going forward. The long-term toxicities of chemoradiation to the pelvis, as I mentioned before, bowel toxicity, decreased bone density, and sexual dysfunction. The acute toxicity is typically a little bit different than the long-term bowel toxicity. Acute toxicity can include diarrhea, rectal urgency, rectal frequency. Acute toxicities from chemotherapy often include low platelet counts, low white blood cell counts, as well as enteritis, which is inflammation of the bowel due to radiation exposure and chemotherapy exposure. Dysuria can indicate that there are some acute risk of genitourinary symptoms. The risk factors for long-term bowel toxicity are the radiation dose, the volume of bowel that's irritated, the fractionation schedule, the concomitant administration of chemotherapy, and then patient factors. So any patient who has had prior abdominal surgery is at a higher risk for bowel toxicity, and pre-existing vascular disease, as seen in patients with diabetes or cardiovascular disease, is also a risk factor for worse toxicity. Bowel symptoms can be variable in terms of when they occur. They can occur any time from 6 months after completion of treatment to 25 years after completion of treatment. The average is 2 to 3 years. And they include abdominal cramping, alternating diarrhea and constipation, malabsorption, bleeding, and in rare cases, obstruction or perforation. This is data that's extrapolated from patients with rectal cancer, a disease that also is treated with radiation exposure to the pelvis. We know that these patients are at high risk for osteopenia, which is decrease in the density of the bone. And in approximately 77% of patients who undergo pelvic radiation for rectal cancer, insufficiency fractures can be seen in the sacrum, the pubic rami, and the femoral neck. So I tend to recommend that patients who have completed pelvic radiation are followed routinely with bone DEXA scans to monitor for evidence of osteopenia or osteoporosis. The third category of late effects is sexual dysfunction, and I'm going to just touch on this because I believe one of the speakers after me is going to go into it in more detail, but I typically see this as an issue that comes up very frequently in surveillance visits with my patients. Women experience early menopause, infertility, vaginal stenosis, and vaginal dryness, and men also experience infertility and symptoms of hypogonadism. In terms of my recommendations for managing the chronic gastrointestinal toxicities, there's a variety of things that can be tried. None of these works for every patient, and none of these has been studied in a randomized controlled trial, but patients anecdotally do benefit from lactose-free diets, adjustments in fiber intake. A BRAT diet is a medically bland diet, probiotics to replace the bowel flora, antibiotics have improved symptoms in some patients, and in some patients oral steroids can be useful. And in extreme circumstances, just a trial of bowel rest and other forms of nutrition can be useful. For bone density loss, I recommend vitamin D and calcium supplementation. Exercise is important as we get older for all of us, even without a history of radiation therapy, to improve our bone density. And then engagement with primary care physicians for routine screening for osteopenia and osteoporosis. So I hear this question a lot: what else can I do, doc? And there's lots of things that we understand are modifiable risk factors, both in terms of preventing cancer, but also in terms of preventing recurrence of cancer. I bring this slide back up. Anal cancer is a really rare disease, and none of this has been studied, particularly in patients with anal cancer. So the slides I'm going to show you subsequently about how I generate recommendations for patients with anal cancer are extrapolations from other diseases that are more common, and which we've been able to study these in a rigorous fashion. There's growing data from patients with breast cancer, colon cancer, ovarian cancer, and prostate cancer that diet actually really impacts disease recurrence. For patients with breast cancer, more than 5 servings of veggies and fruit per day plus 30 minutes of exercise means patients are 45% more likely to survive 10 years. Patients with BMIs of less than 30 are at lower risk of distant metastases after 10 years. In colorectal cancer, which is possibly the closest disease that I can extrapolate from, we know that non-Western dietary patterns, which means a diet that's low in red meat, low in processed grains, low in fat, and low in sweets, is 230% more likely to mean that patients are alive at 5 years after completion of treatment. In ovarian cancer, similarly, we know that more than 5 servings of veggies and fruit per day means that patients are more likely to have survival at 5 years. These are the AICR guidelines for cancer prevention. They recommend choosing mostly plant foods, limiting red meat and avoiding processed meat, being physically active every day in any way for 30 minutes or more, aiming to be at a healthy weight throughout life, and avoidance of smoke and tobacco. Their final guideline is that after completion of treatment, cancer survivors should follow the recommendations for cancer prevention. So all of these rules apply. Why do we think that physical activity and obesity affect cancer risk? Physical activity decreases inflammation, it reduces levels of circulating sex hormones, it protects against insulin resistance, it decreases gut transit time, and it induces enzymes that protect against oxidative stress. Obesity, conversely, increases the inflammatory response, increases circulating estrogens, decreases insulin sensitivity, and increases circulating insulin and leptin. So this slide is just a basic summary of my recommendations for my anal cancer survivors who I follow in my clinic. As per the NCCN guidelines, I recommend 5 years of medical surveillance after completion of therapy. And that is, these guidelines are vague. And typically the imaging practices depend upon the patient, the stages of disease at presentation, and our general sense of the patient's risk for recurrence, balanced against the risk of repeat radiation exposure from surveillance imaging. For exercise, I recommend, according to the American College of Sports Medicine guidelines, 150 minutes a week of moderate aerobic activity and strength training 2 to 3 times per week. Dietary modifications and bone health surveillance with calcium and vitamin D supplementation. So we all know what to do, and you probably aren't hearing these recommendations for the first time. What are the barriers, and what things prevent us from executing these things? Too little time, too little sleep, too much effort, too much food, too much eating out, too much stress, too much anxiety. We all experience these things, cancer survivors or not, and we all confront these issues as we move forward. I bring up fear of cancer recurrence because it's become a research area of interest of mine, and it's something that has been pretty well validated in other cancers as something that negatively impacts cancer survivors' ability to execute the dietary and lifestyle changes that physicians and caretakers recommend. So cancer naturally leads to a fear of cancer recurrence. Every time one undergoes surveillance imaging, this becomes a very, very pervasive part of the cancer survivor experience. And it can, if it, in the negative context, lead to experiential avoidance, where patients can attempt to avoid the feelings of fear of cancer recurrence through reassurance seeking, rumination, body monitoring, and or withdrawal. It can increase cancer recurrence fear, utilization of negative coping mechanisms, distress, and life disruption, and in fact it can decrease our ability to execute values-driven behavioral changes and embracing the dietary and lifestyle recommendations that are recommended. And I bring this up because I think it is a really important topic for patients, especially those of you who are meeting other anal cancer survivors for the first time, to be able to share with one another, because it is something that you independently live with that very few other people who are not cancer survivors can ever understand. My final slide is about hope for the future. So therapeutic advances, and we've alluded to the fact that there is a robust vaccine prevention study that is ongoing. Vaccine therapy for the treatment of anal cancer is also an area of interest, and there is ongoing research into DNA vaccines and therapies to generate cellular immunity against HPV infected cells.